The topic for discussion is dental calculus and scaling and root planing. The calculus consists of mineralized bacterial plaque that forms on the surfaces of the natural teeth and the dental processes. So the bacterial plaque is unmineralized. When it gets mineralized, it is the dental calculus. So depending on the location, the calculus may be supragingival or subgingival. So as you can see in the first picture, the calculus is present above the gingival margin and it is a supragingival calculus. Whereas in the second picture, you can see the calculus which is present below the level of the gingival margin and it is subgingival calculus. An important point is that the subgingival calculus is not visible through the routine clinical examination because it is below the level of the marginal gingiva. Therefore, the subgingival calculus shown in the picture is after the flap reflection. It is not seen in the routine clinical examination. Next, we will see the differences in between the supragingival calculus and the subgingival calculus. The first difference is based on location. The supragingival calculus is present above the gingival margin, whereas the subgingival calculus is present below the gingival margin. The supragingival calculus is whitish or whitish yellow in color, whereas the subgingival calculus is brown or greenish black in color. The supragingival calculus derives its components from the saliva, whereas the subgingival calculus derives its components from gingival exudate. The supragingival calculus is also called as salivary calculus because it derives its components from saliva, whereas the subgingival calculus is called as cerumal calculus. The composition of the supragingival calculus includes more brushite and octocalcium phosphate and less magnesium vitlockite. These brushite, octocalcium phosphate, magnesium vitlockite, these are all the crystalline forms. There are actually 4 crystalline forms which we will be seeing later, but for now remember that there is difference in some crystalline composition in between supragingival and subgingival calculus, whereas the subgingival calculus is having the opposite of that of the supragingival calculus, that is, it is having less brushite and octocalcium phosphate and more magnesium vitlockite. Since the supragingival calculus is deriving its components from saliva, salivary proteins are present in supragingival calculus, whereas the subgingival calculus will not have the salivary proteins. The sodium content is less in supragingival calculus, whereas in the subgingival calculus, as the depth of the pocket increases, the sodium content also increases. Next, we will see about the composition of the calculus. It has inorganic component and organic component. In the inorganic component, there are different kinds of crystalline forms. Around 2/3 of the inorganic component is formed by crystalline forms, whereas the remaining part is formed by calcium phosphate, calcium carbonate, magnesium phosphate, carbon dioxide, and traces of sodium, zinc, manganese, silicon, iron, and fluorine. This inorganic component of calculus is similar to that of the other calcified tissues of the body, whereas the organic component includes mixture of the protein polysaccharide complexes. In this, there is carbohydrate component of around 1 to 9%, which includes glucose, rhamnose, galactose, etc. And in the organic component, we also have the desquamated epithelial cells, leukocytes, and different kinds of the microorganisms. In the next table, you can appreciate that the inorganic component of calculus is similar to that in other calcified tissues of the body. The inorganic content of the calculus is 70 to 90%, enamel is having 96% of the inorganic content, dentin is having 45%, and bone is having 60 to 70%. So nearly similar content of inorganic composition is present in calculus and the calcified tissues of the body. Next, we are seeing the crystalline composition of the calculus. So, around 2/3 of the inorganic component is formed by the crystalline structures. So, these crystalline structures include hydroxyapatite, magnesium vitlockite, octocalcium phosphate, and brushite. The supragingival calculus and the subgingival calculus have the similar hydroxyapatite component, whereas the difference is in the remaining 3 components, that is the magnesium vitlockite, octocalcium phosphate, and brushite. Next, we will see the attachment of the calculus to the tooth surface. There are 4 modes of attachment, out of which the first one is by means of an organic pellicle on the cementum and on the enamel. So here in the first picture, you can notice that the calculus, that is represented by Ca, is attached to the pellicle which is present on the enamel surface and also on the cementum. In the second picture, you can see that the calculus is attached to the enamel and this is present coronal to the cemento-enamel junction. You can appreciate the cemento-enamel junction, and above which you have the Ca, that is the calculus being attached. The second mode of attachment is by mechanical interlocking into the surface irregularities. The surface irregularities may be because of the carious lesions or into the resorption lacunae. So here the picture depicts the calculus being attached to the cemental resorption area. So the CR is the cemental resorption area wherein the calculus is being attached. Next, the third mode of attachment is by the close adaptation. This close adaptation of calculus is taking place onto the unaltered cementum surface. Next, the fourth mode of attachment is the calculus being embedded into the cementum. The penetration of calculus into the cementum. This is called as calculocementum. Okay, so in the picture you can see that the subgingival calculus is being embedded beneath the cementum surface and it is penetrating also into the dentinal surface. Next, we will see the formation of the calculus. By now, we have a clarity that calculus is mineralized dental plaque. The dental plaque is unmineralized, whereas the calculus is the mineralized part of the dental plaque. So this soft plaque whichever is present will get hardened, and this hardening is because of the precipitation of the mineral salts, and this hardening will take place between the 1st and 14th days of the plaque formation, and this calcification occurs within 4 to 8 hours after the plaque formation. So an important point here is that the calcifying plaques will become 50% mineralized in 2 days, and in 12 days they become 60 to 90% mineralized. And remember that all plaque does not necessarily undergo calcification. Some plaque which does not develop into calculus reaches a plateau of maximal mineral content within 2 days. And remember that the early plaque will have little amount of inorganic content, and as the plaque develops into calculus, the inorganic component increases. Another important point is that microorganisms are not always essential for the calculus formation. Even in the germ-free animals also the calculus formation was seen. So microorganisms are not always essential for the calculus formation. Next, we will see the theories regarding the mineralization of the calculus. We are saying that the calculus is mineralized plaque, but how is the mineralization taking place? So the first theory is that there is mineral precipitation that is taking place because of the increased saturation of calcium and phosphate ions. Why is this increased saturation taking place? That might be because of the rise in salivary pH, because of the colloidal proteins that are present in saliva. So these colloidal proteins present in the saliva will bind the calcium and phosphate ions, and thereby the mineralization is taking place. And another third theory is that phosphatase that is liberated from the dental plaque, desquamated epithelial cells or bacteria, these will try to precipitate the calcium phosphate. So because of these three things the mineralization is taking place, and ultimately the plaque is getting converted into calculus. The second theory is that there are some seeding agents. Because of this, small foci of calcifications are developing, and these small foci are getting enlarged. Okay, they are coalescing, they are fusing and forming an enlarged calcified mass. So this concept is called as epitactic concept or heterogeneous nucleation. So these seeding agents, what are these seeding agents? We don't know what are the seeding agents, but it is stated that there are some starting agents. Okay, these agents, okay, these are the starters. They are inducing some foci, and these foci are coalescing, they're fusing and forming a enlarged calcified mass. Okay, the third one is the role of microorganisms. It is stated that filamentous organisms, diphtheroids, Bacterionema and Velunilla species, they have the capability to form the intracellular apatite crystals, and this mineralization will spread until the matrix and the bacteria become calcified. So we have seen three theories. The first one is mineralization because of the increased saturation of calcium and phosphate ions. Second one is because of the seeding agents, and the third one is because of the microorganisms. Next, we will see the etiologic significance of the plaque. It is difficult to distinguish whether the calicles is causing or the plaque is causing the effects on the gingiva, because the calicles is always covered by a layer of non-mineralized plaque, and this calicles makes sure that the plaque is in continuous contact with the gingival margin. So this calicles plays an important role in maintaining and accentuating the periodontal disease, and also creates areas where the plaque removal is impossible. Next, we get into the second topic, that is the scaling and root planing. Though many plaque hypotheses have emerged, still the periodontal therapy is based on the non-specific plaque hypothesis, that is regarding the quantity of the biofilm. So our main aim is to reduce this microbial load. So by performing scaling and root planing, we are making the root surfaces free of the biofilm and the calicles. The instruments that are used for scaling and root planing are the sickle scalers, curettes, hoe chisel and file scalers, and ultrasonic and sonic instruments. So the first instrument you see here is the curette, which is a fine instrument that is used for the subgingival scaling, root planing, and the removal of the soft tissue lining the pocket. So here you can see the parts of the curette, the handle, shank, and the working edge. In the second picture, you can see the working end of the curette showing the rounded toe, face, and the cutting edges. In the next picture, you can see the effect of the different angulations of the cutting edge of the curette to the root surface. In the first picture, we see the correct angulation, whereas in the second picture, the angulation is too obtuse. It is more, whereas in the third picture, the angulation is too acute. So here, an important point that you have to remember is the ideal angulation, the correct angulation for insertion. For inserting the curette is 0 degrees. Okay, but when you are performing scaling and root planing, the angulation should be between 45 to 90 degrees. So the second picture is showing the angulation that is greater than 90 degrees. If it is greater than 90 degrees, this incorrect angulation will result in ineffective removal of the deposits, and there will be burnishing of the calicles deposits. Okay, whereas in the third picture, the angulation is too acute, that is, it is less than 45 degrees. So this results again in the burnishing of the calicles. So if it is more than 90 degrees, the cutting edge, the lateral surface of the blade will be against the tooth surface rather than the cutting edge, and this will result in ineffective removal of the calicles, and the calicles will get burnished, as you can see in the second picture, the obtuse angulation. Whereas in the third picture, you see the acute angulation, wherein the angulation is less than 45 degrees. In such cases, the cutting edge of the instrument is actually not biting into the calicles, so this will also result in burnishing of the calicles. So instead of removing the calicles, the cutting edge will just slide onto the calicles, and this will result in burnishing of the calicles. So for insertion it is 0 degrees, but for scaling and root planing the angulation should be between 45 to 90 degrees. So here in the next picture you can see that the curette is inserted into the periodontal pocket. You can see the 0 degree angulation of the face of the curette against the root surface. Next, in the second picture you can see that the bottom of the periodontal pocket is identified. In the third picture the correct angulation is maintained, and in the last picture you can see that the blade is moved along the root surface in the scaling stroke and the calicles is being removed. The first one is insertion, then we are finding the apical position of the calicles, and the third one you are making the correct angulation, and fourth one you are removing the calicles. In the curettes, we have the universal curettes and the area specific curettes. So in area specific curettes, we have the Gracie curettes. So these Gracie curettes are a set of different instruments, and they are designed for different areas of the dentition. So the Gracie 1, 2 and 3, 4 are designed for the anterior teeth, 5, 6 are for the anterior teeth and premolars, 7, 8 and 9, 10 are for the posterior teeth, facial and lingual, and Gracie 11, 12 is for the posterior teeth mesial, and Gracie 13, 14 is for the posterior teeth distal. In the next table, we see the differences in between the Gracie curate and the universal curate. As already stated, the Gracie curates are the set of many curates that are designed for specific areas and surfaces. We have different curates for different areas, whereas the universal curate is the one in which one curate is designed for all areas and surfaces. So in the Gracie curate, only one cutting edge is used, whereas in the universal curate, both the cutting edges are used. In the Gracie curate, the blade curves from the shank towards the toe, whereas in the universal curate, the blade curves only from the shank and towards the toe and not to the side, whereas in the Gracie curate, it curves to the side. The blade angle is offset angle in case of Gracie curate, that is, the face of the blade is beveled at 60 degrees to the shank, whereas the universal curate, the face of the blade is beveled at 90 degrees. Next, we learn about the finger rest. The finger rest will help us to stabilize the hand as well as the instrument when the movements are made during the scaling and root planing. These finger rests are classified into intraoral finger rests and extraoral fulcrums. The extraoral fulcrums are not actually finger rests, but they are also essential for effective instrumentation, especially in cases of maxillary posterior teeth. So these intraoral finger rests are of four types. The first one, as you can see, is the conventional finger rest, in which the rest is established on the tooth surface that is immediately adjacent to the working area. So whenever you're working on a particular tooth, immediately adjacent to that area, you're taking a finger rest. The next one is the cross arch finger rest, in which the finger rest is established on the tooth surfaces on the other side of the arch. So here in the picture, you can see that when you're working on the third quadrant, you are taking the finger rest on the fourth quadrant. So this is the cross arch kind of finger rest. The next one is the opposite arch, in which the finger rest is established on the two surfaces of the opposite arch. So here, when you're working on the second quadrant, you are taking the finger rest on the third quadrant. This is the opposite arch. Whereas the last one is the finger on finger kind of intraoral rest, in which the finger rest is established on the index finger or the thumb finger of the non-operating hand. Here in the picture, you can see that on the index finger, the finger rest is being established. Next, we see the extraoral fulcrums, in which we have the palm up and palm down kind of fulcrums. So the first picture is palm up kind of fulcrum, and the second one is the palm down kind of fulcrum. Next, we come to the conclusion. So, although the bacterial plaque that coats the teeth is the main etiologic factor in the development of the periodontal disease, the removal of the subgingival plaque and the calculus still forms the cornerstone of the periodontal therapy. So, still the periodontal therapy is based on non-specific plaque hypothesis, which mainly believes that the periodontal disease is caused by the quantity of the biofilm and the calculus. So the calculus plays an important role in maintaining and accentuating the periodontal disease, as it keeps the plaque in close contact with the gingival tissue and makes the plaque removal impossible. Therefore, clinicians must not only possess the clinical skill to remove the plaque and calculus, but they also must be very conscientious about performing this task. So in this topic, we have seen about the calculus, the different types of calculus. There is a supragingival and subgingival calculus. We have seen the differences in between them. We have seen the composition and the composition differences also in between the supragingival and subgingival calculus, the inorganic component, organic component. We have seen the types of attachment or the modes of attachment of the calculus onto the tooth surface. We have seen the theories regarding the mineralization of the calculus, the significance, the etiologic significance of calculus, and next we learned about the scaling and root planing. In the scaling and root planing, we have seen the angulation with which the curate has to be inserted, an angulation for performing the scaling and root planing. Next, we have seen different kinds of finger rests, in which we have seen the intraoral finger rest and the extraoral fulcrums. Thank you everyone for your patient listening, and all the best.